1 or 2 seconds.
Okay.
Yes, madam, you are right to go.
Yes, sir. Thank you so much. Good evening, all students and teachers here. So today we'll be taking, I'll be conducting the class on PPH and related complications and the management of shock associated with that. Previous classes we have spoken about APH. It took almost 3 classes for us to complete the APH, that is antepartum hemorrhage. Today we'll be dealing with the postpartum hemorrhage. Okay, so the definition wise, postpartum hemorrhage is any bleeding that is occurring after the 3rd stage of the labor. So you all should recollect the stages of the labor in the 1st stage, 2nd stage and the 3rd stage. The 1st stage of labor starts from the onset of the labor contractions or labor pains and up till the full dilatation of the cervix. 2nd stage is from this full dilatation of the cervix to the delivery of the fetus, and the 3rd stage is the delivery of the placenta. So any bleeding that starts in the 3rd stage of the labor and after that up till 6 weeks of postpartum period, it is called as the postpartum hemorrhage. Okay, so what I'll do in this class is I'll be telling you about the theory first. We will discuss about the important points involved in this topic, and then we will come to the MCQs of the same thing, right? So by definition, as I told, any bleeding that is occurring in the 3rd stage and after that up till 6 weeks of postpartum period after delivery is called postpartum hemorrhage. For the definition, or to tell that the patient is having a PPH, arbitrarily they have fixed an amount of the bleeding which is occurring post-delivery. So normally the blood loss after the delivery is less than 500 ml, okay, in a vaginal delivery, or 1000 ml in a cesarean section. So any bleeding from the in the woman which is more than 500 ml in the vaginal delivery or more than 1000 ml following a cesarean section is defined as the postpartum hemorrhage. Again, the postpartum hemorrhage is divided into minor and the major categories. In the minor, if the blood loss is between 500 to 1000 ml, it is called as minor PPH. If the blood loss is more than 1000 ml, it's called major PPH. Now, again, this major has been divided into moderate and massive. Moderate is when the blood loss is between 1000 to 2000 ml, and massive when the blood loss is more than 2000 ml. And another definition, which is by the ACOG, that is American College of Obstetrics and Gynecologists, they defined the PPH when there is a drop in the hematocrit of more than 10%. So pre-op or pre-delivery hematocrit, and when you compare the post-delivery hematocrit, and if it is more than 10%, that is how they define to say that there has been a PPH in that patient. So this is mainly a retrospective retrospective diagnosis as to defining it in terms of a drop in the hematocrit. Okay, is it clear to all of you? I hope you're all there. Yeah. Yes, ma'am. So we'll move further. Now, types of PPH. They can be, the PPH is mainly divided into primary PPH and secondary PPH. Primary PPH is when the bleeding is occurring within 24 hours following the childbirth, and the most common cause here is usually an atonic PPH or because of the non-contractility of the uterus. So that is called as primary PPH. And secondary PPH is any bleeding which is occurring after 24 hours of the delivery and up to 6 weeks postpartum. That is called secondary PPH. Here, the most common cause is the retained placenta. So the causes of the postpartum hemorrhage, you can remember it easily by remembering these 4 T's. Now, these 4 T's will stand for the one is tone, okay? Then you have the trauma, thrombin, and tissue. So these are the 4 T's. So related to tone, it is nothing but a loss of or what we call atonic PPH, that is loss of the contractility and retractility capacity of the uterus, which normally occurs immediately after delivery. The uterus fails to contract and retract here. That is called as atonic PPH, and it is the most common cause of primary PPH, that is immediate bleeding occurring after the 3rd stage of the labor, and it occurs for 90% of the cases. Now, the bleeding occurs as the blood vessels are not obliterated by contraction and retraction of the uterine muscle fibers, as discussed. Now, the second cause of PPH is trauma. Trauma mainly to the genital tract, which could be injuries like lacerations of the cervix, vagina, perineum, even colporexis. Colporexis is nothing but there is a through and through tear in the vagina extending up to the vaginal vault and even opening up into the peritoneal cavity. That is called as colporexis, and rupture of the uterus. So these are few causes of traumatic type of PPH. Other cause of PPH, what they have designated in the third T, that is thrombin. Thrombin. So if just to make you remember and relate to, is the coagulopathy, that is thrombin associated with any coagulopathy, though that could be the cause for PPH. So coagulopathy could be in the form of DIC, which is again precipitated by conditions as we discussed in the previous class, abruptio placentae, amniotic fluid embolism, sepsis. There are so many causes. So if a patient has any of these pathologies that lead to DIC, and they are more prone for PPH. Hyperfibrinosgemia, and that is again what you call a coagulation coagulation disease. So these are the causes of PPH, but very rare. Other cause is tissue. Tissue means it is related to any tissue of the or tissue of the placenta or retained products of conception left behind in the uterus. If the uterus is not completely evacuated during the time of the delivery, the retained tissue could be because of so many causes. There could not be proper expulsion of the placenta. There could be placenta accreta or increta and percreta. Those are extreme forms of placental attachments. And if there is a mishandling or mismanagement of the third stage of labor, or using oxytocics very early, resulting in contraction of the uterus too early, and the os also contracts there and the placenta gets trapped. So these are certain situations where there could be retained products of conception, and that will lead to PPH in subsequent stages, or even in the same day, or even most commonly these retained products of conception cause a secondary type of PPH, that is after 24 hours of the delivery. Okay. Now, what are the predisposing factors for PPH? Mainly the atonic PPH. See, here you all should remember that these are the most, the listed points here, though they are more prone for atonic PPH. You should remember that any woman in whose for delivery is always prone for atonic PPH. So you should not be under the impression that if none of these factors are present in a female, then she may not have an atonic PPH. But the other way around is so much true, that each and every woman who is waiting for delivery or in the labor is prone for an atonic PPH, and we never know which woman will end up in PPH. So that's why, though these factors listed here predispose that woman for a PPH or atonic PPH, we should always be ready, or should be prepared, that any woman can go into an atonic PPH. And that's why it's very important that we are well aware of the management of the third stage of the labor, keep the oxytocics handy, and even the blood products are kept in the sense they are reserved, or they are inquired and kept if at all we need in the emergency. So these are predisposing factors which are found most of the times, especially the grand multipara, malnutrition, anemia, previous history of atonic PPH, antepartum hemorrhage, especially if the patient is having a placenta previa or abruptio placentae. As we discussed, placenta previa is because it is attached in the lower uterine segment, and the lower uterine segment's capacity to contract and retract following delivery is too less. That's why there will be more chances of postpartum hemorrhage in such cases. Abruptio will be predisposing to PPH in the form of, if the patient develops a DIC, then she will lead into coagulation failure and PPH. So this is how these two conditions, that is APH, will predispose to PPH. Then over-distended uterus. So here what happens, the uterus is stretched to maximum, and its capacity to contract and retract immediately after delivery would be comparatively lesser than the normally distended uterus. So which are these conditions in which there is an over-distended uterus? It is multiple pregnancy, hydramnios, and macrosomia, that is a big baby. So these three conditions would predispose to an over-distended uterus. and in turn the over-distended uterus will be the PPH is more common in such cases. Preeclampsia, hypertension, obesity, uterine malformations or uterine fibroids also will predispose. These factors will come in hindrance to the contractility and the retractility capacity of the uterus. So these are again important factors, especially fibroid uterus and uterine malformations. Precipitate labor, that is quick labor. What you call precipitate labor is where all the stages finish off within an hour. That is labeled as a precipitate labor. So if there is a precipitate labor, the patients again might end up in atonic PPH, and also in contrary, prolonged labor also. So if the labor is prolonged for more than 12 hours or 24 hours due to any of the reasons, and that would have kind of exhausted the uterus with repeated contractions and during the labor, that will kind of result in exhaustion of the uterine musculature. So that's why post-delivery, the contractility capacity will be lesser. So both these extremes, that is precipitate labor and prolonged labor, will result in PPH. Okay. Then mismanaged third stage of labor. Mismanaged third stage means, as I've discussed, there could be mishandling, there could be like, unnecessary massaging of the uterus, or they could just, if there is an untrained person who's kind of attending the delivery, they just pulling of the placenta, pulling of the cord, or mishandling, or giving these oxytocics not at the right stage, that is after the delivery of the the placenta, or they give it early. So what happens is the uterus contracts and retracts early there, and therefore the placenta gets trapped. So this kind of mismanagement of third stage of labor also will lead to postpartum hemorrhage. Then inadvertent use of oxytocin, as we discussed earlier, use of GA, and that is general anesthesia and epidural anesthesia. This will cause hypotonicity. Especially GA will result in hypotonicity of all the muscles generally in the body, and more so in the uterus, uterine musculature. Therefore, that might lead to again atonic PPH in some cases, especially when the halothane has been used. But nowadays, most of the times, even whatever the type of any kind of high risk patients, general anesthesia is rarely used nowadays, and we are most of the times using spinal anesthesia, which is quite safe. And anesthesia as a predisposing factor for PPH is very less nowadays. Of course, retained placental fragments also will lead to atonic PPH, and that could lead to PPH. The even primary or even secondary kind of atonic PPH will develop in such patients. So these are some of the predisposing factors, but we need to be careful whenever there is a factor, one of these factors are present in the patient. But as I said, any patient can end up in atonic PPH, and therefore we should always be prepared with especially the oxytocics being handy, and any blood factors and the blood to be arranged in such patients. Okay. Other causes of PPH, one is traumatic PPH, as we discussed, which is more common in instrumental deliveries like forceps or even vacuum deliveries. Vaginal birth after cesarean section, sometimes that results in again a rupture of the scar, or the scar gives away, or even the perineal tears and all are more common. That's why vaginal birth after cesarean section leads to traumatic PPH. Not always. Of course, other causes are face to pubis delivery, precipitate labor, and macrosomia. Now, in the face to pubis delivery, as you all know, that the diameter of the delivery is larger than the perineum can accommodate, and therefore, if you do not give a proper episiotomy in such cases of malpresentations or malpresentation deliveries, especially face to pubis delivery, the perineum will be too much stretched, threatened, and it will lead to lacerations and other vulval hematomas and other things like that. So face to pubis delivery, precipitate labor, and also macrosomia. These are again causes of traumatic PPH. Blood coagulopathy, as we discussed, the causes of DIC like abruption, sepsis, intrauterine death, severe preeclampsia, and HELP syndrome. So these are the causes which will predispose to DIC, and therefore are again a cause for PPH. So it's clear for all of you regarding the causes of PPH. Students?
Yes, ma'am.
Right. So remember these 4 T's. It's very important. Tone for atonic PPH, trauma for traumatic PPH, thrombin for any coagulopathies, and tissue is for the retained loss of conception. So remember this 4 important the headings, and under that you will be able to remember the different causes as we discussed in the next slides. Okay. So the diagnosis of PPH is most of the times it is subjective, in the sense when you have conducted about 100 deliveries, you would know what is a normal blood loss and what is a heavy blood loss. So it is most of the time subjective. We actually do not kind of go into all these theoretical assessments when in the labor room. Okay. But of course, the vitals will be all deranged and the patient will go into shock. So those are the extreme or later stages of identification or diagnosis of PPH. But theoretically, diagnosis of PPH is based on the shock index, which is nothing but heart rate by systolic blood pressure. Okay, so normally it should be between 0.5 to 0.7. Right. So this has been used in intensive treatment units and trauma care centers as a guide to estimate the amount of the blood loss. So if it increases above 0.9 to 1 to 1.11, then intensive resuscitation may be required in such cases. And there is also something called as obstetric shock index, or the OSI, where during pregnancy its normal value is 0.7 to 0.8, as we discussed. And if it is more than 9, if the obstetric shock index is more than 1, sorry, it indicates a massive hemorrhage and there is a need for the blood transfusion to be done. There is something called as urgency grid based on the obstetric shock index, and shock index as an urgency grid has been proposed based on the condition of the patient. Are you all able to see the slide properly? I think the table is little.
No, ma'am.
Yeah, I think I'll just adjust that a bit. Give me some time for this. Yeah, I think now it's visible. Fine. So here you can see you're all able to see the screen, right? Hello?
Yes, ma'am.
Yeah,
Yes,
fine.
ma'am.
So
Yes,
I'll go
ma'am.
ahead. This is the first category where the blood loss is about 500 to this is 1000 ml actually, and which is about 10 to 15% of the volume. Here the BP is still normal, and the patient might have symptoms like palpitation, mild tachycardia, and dizziness. And the obstetric shock index is less than 1. And the degree of shock or the urgency when you want to interpret it is a compensated shock. Okay. Or a compensated PPH, where the blood loss is between 1000 to 1500 ml, that is about 15 to 30% of the blood volume. Here there will be a slight fall in the systolic blood pressure, that is between 80 to 100, and there might be a rise in the diastolic blood pressure leading to increased pulse pressure. Okay, this is a compensatory mechanism here, where whenever the systolic BP falls, the diastolic BP will be slightly raised, and therefore there will be increase in the pulse pressure. Now, the symptoms could be like weakness, marked tachycardia, as well as sweating, and the OSI is more than 1 here. It is categorized as a mild variety, but remember here the grading is in the reverse order. So the mild variety is graded as grade 3. Okay. Another thing is the next thing is like when the bleeding is between 1500 to 2000, and there is 30 to 40% of the blood loss. There is a moderate fall in the systolic blood pressure between 70 to 80 mmHg. There is a restlessness, marked tachycardia, pallor, as well as oliguria. The OSI is between 1.5, is more than 1.5 here, and it is categorized as a moderate grade, that is grade 2. when the blood loss is more than 2000 ml, here, as you can see, which is more than 40% of the blood volume, there is a marked fall in the systolic blood pressure, almost 50 to 70, and most of the times you're unable to even record the systolic blood pressure in such cases. So you are able to you'll not be able to hear the faint croak sounds on the systolic blood pressure, especially with the manual sphygmomanometer. So there is a marked fall in the systolic blood pressure. There could be collapse, air hunger, and anuria in the patient, and the OSI is more than 2, and this is graded as a severe grade 1 variety of the degree of shock or urgency in case of PPH. So is it clear for all of you? It is graded as compensated, mild, moderate, severe, that is grade 3, grade 2, and grade 1. Okay. Now coming to the management. Management here in PPH, it has to be very quick, very aggressive, and you will have to do 3-4 things simultaneously. There is absolutely no time for you to even breathe or even sit and think as to what to be done next. So you should be very well coordinating things. You should always call for help in PPH. That is very, very important. The first thing, because it is very difficult to manage alone, because there are so many things to be done all simultaneously, and it is very important. Each and every second and every minute is important to save the life of the patient, especially in cases of atonic PPH. So the general measures in the PPH include resuscitative measures, plus you have to send the investigations in the same time, plus you have to confirm the diagnosis as to what is the cause of the PPH, right? Immediately you need to do a quick assessment in the form of especially per abdomen examination, and try to feel the uterus first. That is the first thing you do whenever a patient is coming for PPH. So once you have assured or you have ruled out that the uterus is contracted well and retracted well, and atonic PPH is not the cause for her PPH, then you go ahead and get into the other factors to be evaluated, right? So always these things have to go simultaneously, hand in hand. That is resuscitative measures, sending the investigations, and confirming the cause or the diagnosis of the PPH, right? So the first and the basic step in the management of PPH is resuscitation of the patient, which includes securing the IV lines. Here always you secure 2 IV lines. Even though the patient, you feel that she's stable, she may not need she may not go into shock, or you'll be able to manage her, but still it is always better to get 2 IV lines, because once the patient deteriorates or she goes into a next stage of shock, it will be difficult for you to even get the IV lines in such cases. So it is always better to secure the IV lines, 2 in number, and always to take a large bore needle, that is 18 gauge catheter has to be inserted. So immediately the volume restoration has to be done by crystalloids, or like normal saline or RL initially, if it is in the mild or compensated degrees. If the patient is in the moderate and higher degree of shock, then you have to use colloids like Hemacil and other things can be used instead of the or before the blood can be arranged, the colloids should be used. And then, of course, the patient will be started on oxygen inhalation. Cross-matching and arranging of the blood should be done simultaneously. Once you insert the cannula, at the same time, you have to take the sampling for investigations, as well as cross-matching and arranging for the blood. So the investigations what are sent are blood group, hemoglobin, clotting time, coagulation profile, electrolytes, etc., to be sent for the evaluation, as to find out what is the cause for the PPH, and also what is the level of the blood loss, and how far you have to manage the patient. So all these things will help in assessing the patient's condition as well as the need for further treatment, right? So these are the general measures. Then, of course, when you're trying to, as I told, trying to diagnose the cause or diagnose the PPH, always it is important to do the abdominal examination and look for the status of the uterus, how the uterus is, whether the uterus is hard and contracted, or whether it is soft and atonic. So that is the first thing you do when the patient is there, and always rule out atonic PPH before you go into the other causes. So when diagnosis of atonic PPH is confirmed, uterus should be massaged continuously and medical method should be adopted simultaneously. This is what you do immediately once you keep your hand on the abdomen, and if you feel that the uterus is soft and atonic, then immediately you start the massage and see that the drugs are given timely. So second step is medical management, especially in atonic PPH. The drugs or the oxytocics which can be given include a range of drugs like oxytocin. I'm sorry about this slide. Actually, it's a little confusing. I couldn't format it better. So here the most commonly used oxytocic drugs are oxytocin. Then you have the methyl PGF2 alpha, that is also called as the carboprost. Then you have the misoprostol, that is PGE1. Okay. And then of course the good old drug, that is ergometrin or methergine, is given. So as we discussed, oxytocin is the first line of drug to be given, and it's also given for prevention of the PPH in the third stage of labor. But wherever there is a PPH, you can give up to 30 to 40 units of oxytocin. And oxytocin, remember, should always be given as an IV infusion, never as an IV bolus. It should always be given as an IV infusion, and or you can give it as an IM injection, but not as an IV bolus. So in case of PPH, the dosage is 30 to 40 units of the oxytocin in about 1 pint of the fluid can be started, and you can start it like in a very high flow rate. So that is how the oxytocin is given. And what are the side effects caused by oxytocin? Usually are nausea, water intoxication, and it has not to be given as an IV bolus, as I discussed. So those are few points to remembering when we have oxytocin. The second drug is the carboprost, which is a derivative of 15-methyl PGF2 alpha, and this is one of the best drugs which is used nowadays, where it will lead to uterine contractility and prevent the PPH. It is given as a dose of 0.25 milligram or 250 micrograms. And very important point to remember when you're using carboprost is that it is never given IV. It's always a IM. It is always IM. That is very important. And it is a second line drug, the first line after oxytocin. If the oxytocin fails to contract the uterus, then you come back to carboprost. Okay. So carboprost, the doses can be repeated after every 15 up till even 90 minutes. You can repeat the carboprost dose. The usual side effects are nausea, the usual side effects are, I'm trying to get the pen here. Okay, forget it. So here the usual side effects are nausea, vomiting, diarrhea, chills, etc. And in cases of bronchial asthma, this is very important to remember that the PGF2 alpha, the carboprost, is contraindicated in patients with bronchial asthma. And any patients with bronchial asthma, if inadvertently, if it is administered, then it will lead to bronchial spasm and respiratory distress. So that is to be kept in mind. And it is also to be avoided in case of active cardiac, renal, or even hepatic disease. The next drug is misoprostol. That is also a prostaglandin derivative. It is a PGE1. The dosage is 200 to 1000 micrograms can be given at a single time for the management of the PPH. And it is given as a single dose. Either you give it per oral, that is orally, or in the per rectal. So it can be given both the ways. Usually we prefer per rectal because the absorption is better and the mechanism of the action is much quicker if it is administered per rectally. So misoprostol usually we administer per rectally, especially for management of PPH cases. The side effects include nausea, vomiting, fever, chills. I think there's somebody trying to come and join. Well, nobody there. Right. So I was discussing about misoprostol. It causes side effects like nausea, vomiting, fever, and tachycardia, and chills. Chills is very characteristic of misoprostol. Whenever we see it very commonly, the patient develops chills and a mild feverish like status immediately after administration of misoprostol. So these are some of the side effects. Also, you have to remember that in case of scarred uterus or is all clear to all of you. The drugs which are to be remembered, the oxytocics which are used for the management of PPH. One is oxytocin in the form of IV infusion. Then we have the carboprost. Hello.
Hello, ma'am.
Yeah, I think it got disconnected in between. So now it's audible, right?
Yes, ma'am. Yeah, ma'am. Yes, ma'am.
Right. So we were discussing about this oxytocics. As I told, the drugs which are used for the management of PPH, one is oxytocin in the form of IV infusion. Then we have the carboprost or the 15. This is 15 methyl PGF2 alpha. Then we have the misoprostol, which is in the form of tablet, and it is given either per rectal or per oral, right? And then the methogen, which is an injection given IV or IM. So these are the four most important drugs or the oxytocics which are used in atonic PPH, right?
Ma'am, screen isn't visible, ma'am.
Oh, the screen is not visible.
Yes, ma'am.
Okay, just a moment. Let me adjust that. Sorry. Yeah, is it visible?
Yes, ma'am. Yes, ma'am.
The slideshow is visible or the other one is visible? Just give me 2 minutes. I think I'll go to the slideshow. Yeah, better now? Hello?
Yes, ma'am. Yes, ma'am.
Right, so we'll continue. So the third step in the management. See, the first step was to go ahead with the general management, that is resuscitation of the patient, sending the investigations and arranging for the blood products. Second step was oxytocics. Third step is the mechanical methods. See, whenever the patient fails to respond to the oxytocics or when the uterus does not contract with oxytocics, when you use stepwise and when you have used the maximum dose of these oxytocics, then you have to immediately take a decision as to go for the next methods of controlling the blood flow or the blood loss there. Those are called as the mechanical methods. In the mechanical methods, we have this bimanual compression, where the uterus is compressed with both the hands, and one in the vagina, it is compressing on the anterior surface of the uterus, and the hand on the abdomen compresses the posterior surface of the uterus. So together, both the hands compressing the uterus in between, that is called as bimanual compression. Then the next step is uterine packing under anesthesia. So this uterine packing is done again to kind of produce an tamponade kind of an effect, or it increases the uterine pressure, and thereby helping in sealing of the blood vessels and reducing the bleeding. So this uterine packing can be an option when you don't have any other option, or a surgical other OT facilities are not available for a proper immediate surgery. Then you can try this method of uterine packing and then referring the patient to the higher center. So one is bimanual compression immediately, then you do a uterine packing as a temporary method where you have to buy time to shift the patient to a higher center. That can be done. Or shifting from even labor room to OT, you can do the uterine packing, before opening up into the OT. That would save a little bit of time as well. Then balloon tamponade is another method what we use, that is with a Sengstaken tube. It is inserted in the uterus. This creates a tamponade effect, and it compresses the placental bed. So it kind of puts pressure on the placental bed, and the vessels are sealed over there, and the bleeding stops. So this is balloon tamponade, which is here they use a Sengstaken tube. The same kind of balloon tamponade effect can be used can be done by using the Foley's catheter also. Sometimes when nothing is available, you have a Foley's catheter in the labor room. What you do is you insert the Foley's catheter within the uterine cavity, and fill up the Foley's bulb with about 20 to 30 ml of the saline, and then you leave it in the intrauterine cavity. This itself will cause kind of a tamponade effect again, and it will compress the placental bed and other walls of the uterus and prevent the bleeding. So this also is one of the options. Then there is something called as Shivkar's pack, where this person has used a condom, and that condom being inflated with the saline, it is tied to a nasogastric tube, and it is first the condom, which is tied to the nasogastric tube, is inserted into the uterine cavity, and then it is instilled with the water or saline, and again, as the effect is the same by a tamponade, and it causes pressure on the uterine walls. So these are some of the mechanical methods where it can be tried on table or on the labor table before actually shifting the patient to a higher center, or shifting her to the OT. So these are some of the measures you can try. So is it clear for all of you?
Yes, ma'am.
Right. So after that, once you have tried these mechanical methods and still there is no control, or it's just like a temporary method you have used, and the final or the next step in the management of PPH, when there is still not controlled, is the surgical method. So here the surgical method will depend on her family status, whether the family is completed or not completed. If there is a atonic PPH not responding to any of your methods, either the medical or the mechanical methods, and when you go ahead with the surgery, if the family is completed, the best thing to do is hysterectomy for such a patient, because this is absolutely life-saving, and you will not have any doubt as to whether your method is going to be successful or no. So once the patient is completed a family and it is a very atonic kind of a uterus, instead of trying with all other conservative methods, you go ahead for hysterectomy. But if the patient is not completed a family and is still quite young and wants to retain her uterus for future fertility, then these are the options what we have. Now, stepwise, we can do all these methods. First one is called as applying the B-link sutures. B-link sutures are nothing but they're vertical suspension sutures which are taken on the uterus. I'll just show the picture here. As you can see, this is the B-link sutures, where what we do is we hold the uterus. Usually we take the uterus out on the abdomen and take the stitches through and through. We take one stitch from the anterior wall, pierce the anterior wall, go inside the uterine cavity, pierce the posterior wall, and come out like this. And these two ends of the sutures are tied on the fundus of the uterus here, as you can see. Yeah, it's tied in the fundus of the uterus here. Similarly, we do two sutures like this, one on this side and the one on this side. So this is a B-Lynch suture, where it is also called as the compression sutures or brace sutures or vertical suspension sutures. So this is one kind of a conservative method what we use for controlling the PPH. A second option is a radiographic embolization of pelvic vessels. If at all you have a very high-end center where there is, the facility for intervention radiology, then radiographic embolization of the pelvic vessels, especially the internal iliac artery, bilateral internal iliac artery embolization can be done by the intervention radiologists. This is one option. Other stepwise, again, the surgical methods which are involved in controlling the bleeding is, first we do try with the uterine artery ligation, then the ovarian artery ligation. If these two still do not control, then we go ahead with the internal iliac artery ligation. Internal iliac artery ligation, we'll discuss that in subsequent slides. You all should remember that uterine artery is a branch of the anterior division of the internal iliac artery, is it not? So that's why ligating the internal iliac artery, especially the anterior division, it's only, not specially, it's only the anterior division of the internal iliac artery ligation, that is as a next step which is done. Okay, so in case, even if the patient, in such a patient which is not completed the family, any of these methods fail and the bleeding is not controlled and the patient's condition is deteriorating further, then as a last resort to save her life, we have to do hysterectomy for such a patient, explaining all the, counseling the patients, attenders and everyone. We have to go ahead with a hysterectomy to save the life of the patient in very extreme situations. So these are the stepwise management of the surgical methods which we usually follow as a protocol in the PPH patients. So we also discussed about this B-Lynch. That's about one of the conservative stitches what we take on the uterus. There have been a lot of different people who have suggested different kinds of suturing to compress the uterine cavity as well as the uterine muscles and to control the bleeding. Few of the important ones, most commonly we follow only this B-Lynch. We don't follow the other methods very often. Sometimes we do this, here you can see in this figure, there is this horizontal cervicoisthmic sutures where they take horizontal sutures in the lower part, that is in the lower uterine segment sometimes, but most commonly we just do the B-Lynch. Okay, so there are several other sutures which have been explained like Heyman suture or Cho sutures or Gunshula sutures. This, what you can see here, the square stitches, these are the Cho square stitches. Here what we do is we take the bite on the anterior wall, then we kind of take it inside the uterine cavity, get it out through the anterior wall, then pierce the anterior wall, take it through the posterior wall and get it out inside and out. So again tie it off. So these kind of 4 stitches of square stitches are taken along the uterine body. Okay, so this is Cho squares stitches, which is most not very commonly followed. Most of the times what we follow here is the B-Lynch sutures. Right, as I discussed in the previous slides, the stepwise ligation of different arteries of the supplying the uterus, that is the uterine artery, internal iliac artery, especially the anterior division as we discussed. And here you can see in this figure, it's very important whenever you're doing this procedure to identify all the pelvic structures properly. So you to identify that it is the internal iliac artery, you have to always go back, trace the common iliac artery and trace this bifurcation of the common iliac artery always, so that you're sure that it's not the external iliac artery what you're ligating. So trace it back to the bifurcation of the common iliac artery, identify this is the external iliac artery what you are seeing here, and this is the internal iliac artery. Once you have identified the bifurcation, the external iliac and the internal iliac, try to identify the anterior division of the internal iliac artery, and this is the posterior division of the internal iliac artery. So this is the anterior division of the internal iliac artery to be identified, and you can see the uterine artery supplying on this side, that is on the medial side. So this is the point where the internal iliac artery ligation has to be done. Before the ligation, it is always again important to identify the ureter, so that you can see here, this is the ureter, and the identification of the ureter is one important step you should never forget. How you identify the ureter on the table is, one is because of its soft structure, or it's quite a soft and rigid structure, and the pulsatility or the pulsations which are seen in the urine flowing through the ureter. That is one important characteristic feature where you can identify the ureter. So identify the ureter, identify the common iliac artery, and identify the anterior division of the internal iliac artery. And when you're taking the stitches actually, or when you're taking the the thread over the iliac artery, it is very important to kind of be aware that the internal iliac vein will lie just below the internal iliac artery. So most of the times, if you take it blindly without being careful about the vein, and then you will end up in poking or rupture of the vein sometimes results, and that's why it is very important to be aware that the internal iliac vein lies just posterior to the internal iliac artery, and when you're taking the bite here, it is important that you prevent that structure. Right, so this is about internal iliac artery. So this slide reads the same thing here. Another important thing is that if you want to make sure that you don't want to ligate the external iliac artery, always you try to compress the external iliac artery and try to feel the femoral and the femoral artery in the thigh. Okay, so whenever as it is, you all know that the external iliac artery gives rise to femoral artery, and subsequently it supplies the lower limb. So it's important to identify the external iliac artery by feeling the pulsations of the femoral artery after the ligation. It is you should be able to feel the femoral artery pulsations, which shows that there has not been an inadvertent ligation of the external iliac artery. So is it clear to all of you? Any doubt in this one?
No, ma'am.
You're clear with the stepwise ligation of different arteries and then the internal iliac artery anatomy?
Yes, ma'am.
Right, so we proceed further. As I discussed, this is one of the options, that is arterial embolization of the internal iliac artery, which can be done radiographically, but you need a very good setup for this. You need a proper, cath lab like setup, and you need an interventional radiologist who is well versed in doing this. If you have this, this is very good, because here it is non-invasive. It's a non-surgical procedure. The patient need not be really anesthetized for a longer time, and it can be quickly done, and the morbidity will be lesser, post-op complications will be lesser. So this is a very advantageous procedure, and immediately the patient will kind of respond, and the gain back the blood loss is controlled, and she becomes stabilized early. So if you have a facility for this, it is very good, but most of the times it is not available in majority of the centers. We have to rely on our surgical methods only. Okay, so hysterectomy is the last option. As I discussed, when all the methods fail, the patient ends up in hysterectomy as a definitive method and the life-saving method. Okay. So here is one algorithm for you people to remember in the management of PPH. If you take this mnemonic as a hemostasis, where each of the alphabet will stand for one particular strategy for management. So as you can see, H here stands for help. So whenever there is a PPH, the first thing you do is in fact shout out and say that I need help. There is a PPH, please come. So whoever is available with you in the labor room or in the OT, call them immediately, because it's a very, as I told, very critical situation, and the time is very important here. Multiple things have to be done at the same time. So always ask for help, and H stands for help, and hands on the uterus. So first thing you do is you keep your hand on the uterus and see whether it is contracted or no, to diagnose whether it is an atonic or a other kind of a PPH, right? So H stands for help and hands. E stands here for establishing the etiology. Ensure the ABC. Ensure the ABC. ABC is your airway, breathing, and circulation. So whenever the patient is in shock, see that first the airway is maintained, the breathing is good, and the circulation is maintained, in the sense you put her the IV cannula, start her on IV fluids, and stabilize her. So this is the next or the immediate step what we do. Establish the etiology by keeping your hands on the uterus, ensure the ABC, ensure the availability of the blood, and ecobolics, that is the drugs. Ecobolics means the oxytocics, so the drugs that contract the uterus. So it's always important that you keep these drugs in the emergency cart of the labor room, but make sure that everything is available, and there is no expired drugs available. So many times you miss it out, so ensure that all is in place and in a proper state. So E stands for establish etiology, ensure ABC, ensure availability of the blood, and ecobolics, that is the oxytocics. M stands for massage of the uterus in case of atonic PPH, as we discussed. O stands for oxytocic infusion or prostaglandins. S is shift the patient to theater in case of the blood pressure falling down, or even an anti-shock garment. There is something called as an anti-shock garment. We didn't discuss about this, but you all should remember that there's something like a garment which is used. It's a whole body covering garment, and that kind of the patient is wrapped in it, and then it is helpful only when the patient is being shifted from one place to the other for further the further higher level of management in terms of surgery and all that. So it's a garment where the patient is wrapped in it, and it is tied tightly over the whole body, and this will prevent the patient from kind of going into further deterioration of the shock, and that can be utilized as a temporary phenomenon during the shifting of the patient. Okay, so this is S stands for shift to theater, that is immediately after if there is a fall in the aortic pressure, along with an anti-shock garment. Then T stands for tamponade, that is balloon tamponade or uterine packing, as we discussed earlier. So here again, one more thing what you have to remember, tranexamic acid is another drug which we can use in postpartum hemorrhage. That will again reduce the bleeding to some extent. So tranexamic acid also is a drug which we can use for the control of the postpartum hemorrhage. So that's important point here. A stands for apply compression sutures on the uterus. That is all these compression sutures what we discussed, that is B-Lynch, Chose, or whatever. These can be used as a measure after you have used your oxytocics or pressure or mechanical methods. Then S stands for systemic pelvic devascularization, that is uterine artery, ovarian artery, followed by internal iliac artery ligation. Of course, I, if you have an interventional radiology, I stands for interventional radiology. S stands for subtotal or total hysterectomy. See, most of the times when we do a postpartum hysterectomy for other atonic PPH or even rupture uterus, or sometimes because of any other cause, most of the times we do a subtotal hysterectomy here. We don't do a total hysterectomy, because total hysterectomy is a very challenging procedure, in the sense the anatomy is very much distorted, the cervix is loose and hanging and dilated most of the times. Okay, so it is very difficult to identify the proper plane between the cervix and the bladder. And if you try to do a total hysterectomy, that is you want to remove the cervix also during the hysterectomy, then chances of injuring the pelvic structures like the bladder especially and the ureters is very, very high. That's why we don't go for total hysterectomy in cases where we want to do a hysterectomy for PPH, rupture of the uterus, or even fibroid sometimes. Then we end up only with a subtotal hysterectomy, where the cervix is left behind and the uterus is removed just above the cervix, that is above the just at the level of the lower uterine segment. The hysterectomy is performed, and the body and the upper part of the the fundus is only removed and the cervix is left behind. That is called a subtotal hysterectomy. And we don't do pan hysterectomy here. We leave behind the tubes as well as the ovaries. So we do only hysterectomy, and that too subtotal hysterectomy. Even the cervix is left behind most of the times. So this is a mnemonic for you to remember about the management strategies for PPH. Okay, hope it's clear to all of you.
Yes, ma'am.
Yeah, okay. So here, all this while we discussed about atonic PPH. Now coming to traumatic PPH, the most common cause for traumatic PPH is the genital tract trauma. The most common site is a pelvic hematoma, is the vulva. Then the artery most commonly involved is in the vulval hematoma. It is the pudendal artery, and it is a branch of the uterine artery only. Management, most of the times, if the small hematoma, then we have to evacuate, and then we have to send the blood investigations if at all there is any derangement in the the parameters. This is actually irrelevant here, these points, so I'm sorry about this. So management will depend on the how big is that, how big is the hematoma, and we usually incise and drain it off and try to find out the bleeder and ligate it on table. So that's about traumatic PPH. Sometimes the vulval hematoma is easily treatable, but if there is a colporexis or there is a even cervical bleeding and all that thing, if it is not clearly visible, then even in traumatic PPH, we might have to end up in surgical procedures, like we open up the abdomen again and go with the serial devascularization of the uterus by doing a intranatal ligation followed by even internal iliac artery ligation to manage this traumatic PPH sometimes. And other drugs which can be used, the oxytocics won't help here in traumatic PPH, as you all know. The tranexamic acid, which I discussed earlier, which can be used in both atonic as well as traumatic PPH, it will help to reduce the bleeding to some extent. So tranexamic acid can be used here, and if the hematoma or the bleeder is identified, it can be sutured vaginally, but if not, then we'll have to open her up, take her for surgery, and go ahead with the again serial devascularization with the different arterial ligations as we discussed. Okay, so this is about traumatic PPH. This management is related to probably the third cause of PPH, that is if there is any coagulopathy or DIC, and in that case we need to treat the patient by supplying her with adequate amount of blood transfusion, also FFPs, platelet transfusion. If the patient is in DIC, we need to replace all these blood and blood products and save the life of the patient and reduce the bleeding in such cases. So is it clear to all of you? Hello students, are you there? I hope there is no disconnection.
No, ma'am. Everything is fine.
Yes,
Fine. Right. So we'll go ahead with the other causes of postpartum hemorrhage. There are conditions like abnormalities in the placental attachment, what we call as placenta accreta, placenta increta, or the placenta percreta. So placenta accreta is where the placental attachment is invaded the the basal plate of the decidua basalis, and it is entering into the myometrium, or just above the at the level of the decidua basalis. So that is called as placenta accreta. Here, where in this variety, the placenta is firmly adherent to the uterine wall. It is, as we discussed, because of the absence or there has been a damage to the residua basalis, and there is a loss of this fibrinoid layer, or called as Nitterbuch's layer. So here it is mainly because of the residua, defective residua formation, and pathological findings are that there is an absence of residua basalis or the Nitterbuch's membrane, and the chorionic villi are attached to the superficial myometrium. Remember, they don't penetrate the myometrium here in placenta accreta, but they are just attaching to the myometrium superficially. So that is placenta accreta. Here, the next stage is placenta increta, where the placental chorionic villi are invading the myometrium. So when they invade the myometrium, that is called as placenta increta. Percreta is an extreme variety where the villi will penetrate the full thickness of the myometrium, and also you can see visibly outside the uterus, even up to serosal layer of the uterus. So this is placenta percreta. So these three grades are important to remember: placenta accreta, increta, and percreta. Okay. What are the risk factors for these conditions? You have the placenta previa, and also if there is a history of operative interference on the uterus, mainly that is in the form of either previous cesarean section, previous curettage, that is DNC, previous manual removal of the placenta, previously treated Asherman syndrome, synecholysis, myomectomy, and even advanced maternal age. So these are some of the risk factors where the patient will be predisposing to placenta accreta, increta, and very rarely percreta. Cesarean section is the most common cause, and we see very commonly in a previous cesarean section, especially as and when the number of the cesarean sections increase. That is, if the patient is having one cesarean section, 2 or 3 cesarean section, the rate of the incidence of placenta accreta also increases. So these are some of the factors associated with this condition. Then, as I discussed, highest rise of adherent placenta is with previous LSCS. It is made, diagnosis is made mainly during an attempt of manual removal of the placenta, when the plane of the cleavage between the placenta and the uterine wall cannot be made out. So prior to delivery, there are certain conditions where we do diagnose the presence of placenta accreta, especially on a transvaginal sonography. There is a visualization of irregular vascular sinuses with turbulent flow, and the myometrial thickness is less than 1 mm. And if there is an absence of subplacental sonolucent, sonolucent zone Q, which represents the normal decidua basalis, indicates a placenta accreta. So what you have to remember is, when there is a uterus here, and then the placental attachment is present here, as you can see. So this is the endometrial cavity, or the endometrium, and then you have the myometrium here. Okay, so there is a sonolucent area. Sonolucent means it is a darker area, right? So in the sonography is nothing but different shades of gray, is it not? So normally, when there is the presence of the decidua basalis is normally present, then this area behind the placenta, where it is attached to the uterine wall, you can see a dark space here. The dark color or a black colored area is seen nicely here. That is nothing but a sonolucent area. So whenever this sonolucent or a dark space is absent, and you can see that the placenta is directly in contact with the myometrium, that is the time when you suspect that the patient could be having a placenta accreta. So this way, by transvaginal sonography, you can diagnose the presence of placenta accreta with the loss of this sonolucent area behind the placenta and the myometrial interface. So this is one of the important signs to remember. Once you suspect a placenta accreta on transvaginal sonography, usually we subject the patient to an MRI and see actual, the features or the presence of the placental chorionic villi attached to the myometrium, or even you can diagnose the grade, whether it is placenta accreta, percreta, or even increta, and the degree of the placenta getting into the myometrium can also be very clearly assessed by an MRI. So whenever we suspect a placental attachment abnormality by a transvaginal sonography with the loss of the sonolucent zone, then we subject the patient to an MRI and try to get more details about this particular problem. Is it clear to all of you? Hello? Hello, students?
Yes, Hello, students. Yes, ma'am.
Yeah, there was no disconnection, right, in between?
No, ma'am. It's
Okay.
okay, ma'am. It's clear.
Right. So let me continue in that case, because if I don't get any answer from you all, I'm not sure if we are connected. Okay. So please respond as and when I'm stated.
Yes, ma'am.
Right. So going ahead with the placental abnormalities, as I said, one is a transvaginal sonography. Next is a Doppler imaging, which shows a distance less than 1 mm between the uterine serosal bladder interface and retroplacental vessels. And the presence of a large interplacental legs is also an important marker to diagnose the placental abnormalities. So complications which can be present in such cases are APH, rupture of the uterus even before labor. There could be a silent rupture where the myometrial invasion is so much that at the site of the previous scar of the cesarean section, it will give away even before the patient goes into labor. So such times, what will end up, the patient will go into uterine rupture. Of course, postpartum hemorrhage is an important complication, an infection or even inversion of the uterus. Sometimes when you try to pull the placenta and it is completely, have attached to the uterine wall in terms of accreta or increta, and if you inadvertently try to pull the placenta along with the cord down to separate it, it will end up in inversion of the uterus sometimes. So these are important complications which can arise because of the placenta accreta or increta or even percreta. Okay. So management here, it will depend on how morbidly it is adherent, the placenta. You can remove it piecemeal and try to followed by actively contracting the uterus with the help of oxytocics. Even the hemostasis can be maintained by taking sutures over the placental bed after you have removed the placental tissue. Of course, you try to do conservative management if the patient is not completed a family. And in such cases also, you can go ahead with the devascularization by uterine artery and internal iliac artery ligations in such cases. Or if the patient is completed a family, go ahead with hysterectomy. In extreme cases, especially in placenta percreta or increta, you can go ahead with the hysterectomy if the patient has completed a family. Conservative approach, you can cut the umbilical cord as high as possible, and then the patient should be given antibiotics. And we have also tried, the patients have been also tried with giving methotrexate, in the hope of autolysis. In the sense, we remove as much of the placental tissue as possible, and whatever little bit is attached to the uterine surface is left behind, and then we give the methotrexate post-operatively to the patient in anticipation that methotrexate is a chemotherapy drug. Is it not? It's a chemotoxic drug. So it does have an effect on the chorionic villi as well. So it will help in autolysis of the chorionic villi, and subsequent prevention of the bleeding can also occur. So what is done is the patient is subsequently managed, or she is monitored by serial beta HCG blood investigation. We do the beta HCG analysis, and once the beta HCG blood levels are coming down and it shows that the chorionic villi are getting autolyzed, and whatever the little bit of the placental tissue which we had left inside is getting autolyzed, and it is kind of getting decayed, and the patient is getting kind of cured from this placental attachment. Okay, so the patient is put on a beta HCG monitoring, and of course, anytime if the patient's condition deteriorates, she ends up in heavy bleeding, that is a time when we again have to go back to the conventional methods of the blood, vascular devascularization, or you go for hysterectomy as well. Okay. So this is one important point you should remember. A conservative approach can also be used in stable patients with a very little placental tissue left behind. Methotrexate can be used as an option in such cases. Okay. Coming to another complication in the third stage of labor, which might lead to PPH, is a uterine inversion. Okay, so in this condition, what happens is the uterus is turned inside out. In the sense, inside out means what happens is if this is the uterus normally, right? So what happens is inside out, it becomes like this, where the fundus kind of drops inside and comes down, and it's kind of either sitting in the vagina or even outside the vagina in extreme cases. So this is called as uterine inversion. It's a very rare cause of postpartum hemorrhage or collapse, and it occurs usually suddenly after the labor, after the third stage of the labor. It is usually acute in onset, and most of the times it is because of the mismanagement of the third stage of the labor, as we discussed, when an attempt to deliver the placenta by cord traction, that is the Credis method. So that will end up in, when you put an inverted pressure, what happens is the fundus is pulled down along with the uterine, along with the placenta, and could result in acute inversion of the uterus. So spontaneous inversion can occur when the uterus is atonic, especially. So what happens is, since there is no tone of the uterus, it kind of, because of the gravity or whatever, it just falls down. So spontaneous inversion also can occur, but it's quite rare. Placenta accreta is a rare cause. So the degrees of uterine inversion it is categorized depending on how lower down is the fundus reaching, into the genital tract. So here you can see the first degree is where there's just dimpling, in the sense, if this is the uterus, and it's just a dimpling here, just a small fossa kind of a thing is seen. That is the first degree. Second degree, or the partial third degree, or it's also, that is the second type, and then you have the partial second degree or partial, and third degree, that is also complete dimpling is seen. So what happens in these kinds is the further depression is seen, that is called as a second degree, where the fundus reaches the internal os, or it protrudes through the internal os, that is the second degree. So just a moment, I'll just try to make some space here. So this is the normal uterus. This is kind of first degree inversion, where there is just dimpling. And if you see, this is the level of the internal os. Here, usually the level of the internal os. So any inversion extending up to the level of the internal os is the second degree. And if it is extending beyond the level of the internal os and coming outside the the vaginal introitus. So just imagine if it's completely outside, protruding at the introitus of the vagina, then it is a major degree or a third degree kind of uterine inversion. So is it clear to all of you? I'm sorry, the slide is a little jumbled. I couldn't really format it properly, and couldn't really get the pictures to make you understand. But I hope these figures made you understand the various degrees of uterine inversion.
Yes, ma'am.
Right. So we'll go ahead. How do the patients with, in case of uterine inversion? Here the patient goes into shock immediately. Okay, here the shock is not a shock because of the bleeding, because it is mainly a neurogenic shock, or a neurogenic kind of a shock. So that's why the patient, once the uterine inversion occurs, immediately she ends up in shock. And later, because of the atonicity, there could be atonic PPH and the shock ensuing because of the hemorrhage as well. Bleeding is due to the attempts to detach the placenta before correcting the inversion. Vaginal examination will reveal a soft globular swelling in the vagina or the cervical canal, and an abdominal palpation, the fundus of the uterus is felt to be absent. Okay, you can, because of that deficiency, you cannot feel the continuity in the fundus at all. So that sensation of loss of fundus of the uterus will be seen on abdominal palpation. So these are some of the features where you can diagnose a uterine inversion. Now, the management in case of uterine inversion, mainly it is resuscitation and try to replace the inverted uterus if you have diagnosed it immediately after the delivery of the placenta. Then you try to invert it at the same go. Okay, if it has not been diagnosed and then there is there has been a time lag to diagnose, then of course the next step would involve one is resuscitation of the patient. Manual replacement is the best step if it is diagnosed immediately, as we discussed. And here you have to remember how do you do the manual replacement is the part which comes out first has to be reposited first. So here, if you can imagine, if this is the inversion and the part which has come first is the fundus actually. So what you do is you try to push it. This has to be replaced at the end. So the part which comes first, that is the fundus, should be the last one to reposit. So you try to reposit the others, these structures or the lateral walls first. When you're keeping your fist here, with the fist you try to push this. First, you try to push these structures with your left hand, stabilizing the uterus. You push these structures, and then the last thing to go back in the reverse order will be the fundus. Okay, so this is how you have to imagine and remember how the manual replacement of the inverted uterus can be done immediately once it is diagnosed. Okay, so once it is replaced and you're sure that the fundus has gone back to its position, then you don't remove your hand. Usually you keep your fist within the uterine cavity, and with the left hand you stabilize, and you, with both the hands, you hold it for a time at least like 15 to 20 minutes, and at the same time you give the oxytocics. Injections are given so that you promote the contraction. And once you're sure that the uterus is contracted and there is no kind of laxity, so that it will not again recur and come back and invert again, once you're sure only, you will remove your hand out. Okay, so oxytocics are given simultaneously. Once the replacement is done, you hold your hands there for some time, make sure that it is well contracted and it does not recur, and then slowly you remove your hand. So this is called as a Johnson's maneuver. So all this technique, whatever we discuss, that is a manual replacement of the uterine inversion, is called as the Johnson's maneuver. Then there are other several methods which have been incorporated for uterine inversion. There is something called as hydrostatic O'Sullivan method. What they do in this method is a warm saline solution is run into the vagina, the high pressure, and then the labia is kind of opposed to prevent the leakage. So under pressure of this normal saline, the warm saline, the natural repositioning of the uterus will occur and the inversion will get corrected. So this is one method, that is hydrostatic O'Sullivan method, which is also called as a warm saline, where the warm saline Hello? Hello?
Yes, ma'am.
Yeah, are you all with me?
Yes,
Yeah,
ma'am.
ma'am.
Yeah, I think there was a call in between, so I was not sure if there has been a disconnection. So we were discussing here, one is the vaginal balloons with the fluid, and even this helps in correction of the inversion. Then if these methods fail, that is, a manual replacement by Johnson's maneuver or this trying with the hydrostatic or vaginal balloons, if they fail, then we go ahead with the surgery. There are different methods which have been tried for uterine inversion for the surgery. The most common is the Huntington's repair. Here, what they do is they pull up the uterus back on. This is of course per abdominal procedure. The traction is given on the round ligaments with the Alice forceps, and they pull up the inverted uterus and then kind of fix the round ligaments and ligate the round ligaments or plicate the round ligaments. This is called as Huntington's repair. There is another method. If this fails, then it is called as Holtein's method is adopted. In this method, what they do, the Holtein's method, you can see here, the cervical ring is incised posteriorly with a longitudinal incision. So here the uterus will be down, is it not? So the cervical ring will be present here. Means the cervix will be constricted and it will be forming a ring at this level. Is it not? So what they do in this operation is the cervical ring which is formed, they cut it in the posterior side. They cut it on the posterior side and then they pull the uterus into the abdominal cavity. And after that, the incision is closed with interrupted sutures. So this is called as Holtein's operation. So in the Huntington's method, what they do is they just try to pull the uterus with the help of the holding the round ligaments and pull it up. If that doesn't work out, or if that fails, then you do the Holtein's method, where as you can see here, the cervical ring will be present. A ring of the cervix will be present here, and the uterus will be actually down. The fundus will be actually down, is it not? So what they do is they cut the cervix and posteriorly, longitudinally, and then they try to pull it up. So that it's nothing but making a space or releasing that constriction ring by the cervix. They release that tension and release that constriction ring and pull up the uterus, and then tie the round ligaments, plication, and then they close this incision on the cervix. So this is called as Holtein's operation. So is it clear to all of you the different methods and the surgical procedures which are used for this thing, for the uterine inversion?
Ma'am, please repeat Huntington's repair.
Huntington's. See, as we discussed, Huntington's is here. What they do is they just give a traction on the round ligaments. See, whenever there is a uterine inversion, what happens is, if you can imagine here, the tubes will be here, the round ligament will be here, is it not? Normally. So with the uterine inversion, what happens? The fundus along with this adnexal structures, that is the tubes and everything, will go down. Okay, see, it will be kind of a depressed here like this, and the tubes and the ovaries will be dragged inside. They'll be lying here, actually, the tubes and the ovaries. But the round ligament, if you can see, the round ligament is attached to the cornu of the uterus, and then the other end is attached to the, it passes through the inguinal canal and it is attached to the abdominal wall, is it not? The round ligament.
Yes.
Yeah, so you can still see the round ligaments on the laparotomy, or when you open the abdomen, you won't be able to see the tubes or the ovaries which are dragged down here. You will be able to see the round ligaments which are attached to the abdominal wall. Okay, so what they do in the Huntington's repair is they try to pull, they will put a traction on these round ligaments and they'll try to lift the uterus with the help of the traction on the two round ligaments. So that if you pull the round ligaments, this will kind of come up with the traction with the help of an Alice forceps. Alice forceps is nothing but a toothed instrument, and we hold both the round ligaments with the Alice forceps with both the hands, and then put a traction on the upward side, so that with the help of this traction, the round ligaments will be lifted up, and along with the round ligament, both the cornu of the uterus will also come along with it outside, and kind of the inversion will be reverted back. Got it?
Yes, ma'am. Thank you.
Yeah. So if this method fails, sometimes what happens, you can see the cervix will be here, and as the cervix will kind of collapse after delivery. So it will form a cervical ring kind of a structure. If it is not, the cervical ring is not tight enough, and when you try to pull the uterus up with these round ligaments, it will usually come up. and the inversion is corrected. But if the cervical ring is too tight, okay, if it is too tight, and sometimes when, as we discussed with the different degrees of inversion, you can imagine that this is the uterus, this is the cervix and the internal os. So in the major degree inversion, what happens, the cervical os will be here, and the fundus will pass through this cervix, and then it will come out in the introitus. This is the vagina. It will come and lie in the introitus. That means it is even passing the cervical ring or the cervix. Understood? So if the cervical ring is loose enough, then this Huntington's method will work, where you can pull up with the round ligament and you can get back the uterus into its position. Whereas if this constriction ring is very tight, it is like just 1 or 2 fingers tight, and in spite of your repeated pulling efforts through the abdomen by the round ligaments, it may not come up. Okay, so in that circumstances, what they do is this Holtein's method, where they incise the cervix posteriorly. They cut open the cervical ring. Okay, and then they cut open this. Once they cut open this, what happens is that pressure or the constriction is released. Okay, so once the constriction is released, they have a proper space from where they can pull up the uterus, and then the position or the inversion is reverted back, and the uterus can come to its position. So this is Holtein's method. And then, of course, whatever the cut they have taken on the cervix, it is sutured back. I hope it is clear to all of you. There's no more confusion.
There's no more confusion. Yes, ma'am.
Okay, so I think I'll stop here. Today, as I told, I have discussed all the theory part related to postpartum hemorrhage. So it would help, all the newcomers as well as students who are still doing, still in their final year or even the second, third phase, so that the basics are clear. And in the subsequent class, we will discuss about the MCQs related to the PPH. Okay.
Okay, ma'am.
So, any doubts, students, regarding this topic? Yes, anybody? I hope it is clear to all of you. So I can see Chaitanya, Anuganti, Radhika.
Yes, ma'am.
Right. So I hope the session was good and you could understand all the points discussed regarding the PPH.
Yeah, ma'am.
Right. So we will stop here if you don't have any doubts. And in the subsequent class, as I told, we will discuss related to this topic. Okay.
Okay, ma'am.
Right. So see you in the next class, and thank you again for attending this class. And in between, if you have any doubts, please contact me on the WhatsApp or even personal WhatsApp number. Okay.
Okay, ma'am. Thank you, ma'am.
Right. Thank you.
Okay, ma'am. Thank you, ma'am.
Thank you. Yeah. Good night.